All right. Hello everyone. This is Sagar here. So today I'll be explaining about the peptic ulcer disease and also gastroduodenal ulcers in general. So the peptic ulcer disease, in short PUD, which is how it's used for the rest of the document, is basically a complication of a chronic gastritis. So when you have gastritis for a long duration of time, which is chronic, that's when ulcers are usually formed. So there's basically chronic mucosal ulceration, okay? And this ulceration, this ulceration can be either in the duodenum or within the stomach itself. Now, the definition of ulcer is basically a breach in the continuity of the skin, the epithelium, or the mucous membrane that can be caused by the slowing off of inflammatory necrotic tissue. Now, with regards to peptic ulcer disease, if you remember from my previous video where I spoke about chronic gastritis, NSAIDs and H. pylori infection are very, very common in causing chronic gastritis. So, peptic ulcers are naturally associated with the two etiologies. Now, once again, to refer back to my initial video, the reason why we have gastritis in the first place is due to an imbalance in the mucosal defenses and the damaging forces. By damaging forces, I mean the gastric acid, and for example, let's say H. pylori, and the mucosal defenses. There are multiple different types. You have the mucus itself, then you have proper circulation, you have prostaglandins, you have regeneration of the epithelium of the gastric wall, etc. Now, peptic ulcers can be acute or chronic. So in acute situations, their margins are not elevated, but they are more or less sharp. You can find several, and they usually have fibrin and necrosis associated. That's why you have an ulcer in the first place. And definitely inflammation. That's like a no-brainer. For chronic, again, you still have inflammation, right? But what you will see is also something known as a radial plicae or radial folds. Essentially, you have in this picture, you can see that there is a center, right? And then you have the gastric folds radiating from the center. Now, this is more common in the duodenal ulcers rather than gastric ulcers, but this is a common feature. Um, you also can find fibrillar necrosis. And if you remember fibrillar necrosis from general pathology, it basically means you have a necrotic damage to the blood vessel wall, mostly due to a hypersensitive type 3 reaction or type 3 hypersensitive reaction due to immune complex deposition, etc. But um, it's ultimately going to result in the leakage of proteins, including fibrin, into the wall. And here you'll find granulation tissue, okay, and also fibrosis that are occurring because this is chronic. Now, the chronic type of ulcers are usually near the antrum or near the duodenum or in the duodenum. So if you look at this picture, you basically have the slugging of the tissue over here, right? You have necrotic debris. You have some inflammatory cells over here. You have some granulation tissue with neutrophils and fibrin and etc. And you have fibrosis occurring underneath. These are nothing but the neck cells. I mean, not neck cells. These are the surface mucosal cells. Here you should ideally be finding neck cells, etc. But yeah, it's necrotic. And also, this is another picture. You can see over here that there is a small ulcer, right? It's roughly like 1 centimeters in diameter. And here you can see that it's pretty shallow. It's not too deep. Okay. And that's why it's still an acute form. And you can also see that there's surrounding hyperemia, there's redness, and you can see that there's some sort of it looks liquidy, and there's some sort of a covering, right? This is nothing but a combination of inflammatory tissue, necrotic tissue, can have some fibrin, etc. Now, if you look at this, okay, here you can see H. pylori related ulcer, okay, but this is basically in the duodenum. Um, and over 85% of all duodenal ulcers are usually associated with Helicobacter pylori infection. Okay, here there's another picture through which using endoscopy you can see that there's an ulceration. All right, so as I mentioned earlier, you have H. pylori and you have NSAIDs, which are the main causes. NSAIDs are going to block the production of PGE2 and PGI2, right? And these are very much important in regulating the overall defense mechanisms of the stomach, be it uh, with relation to the gastric mucosa or be it with relation to the the blood supply in order to remove the excess H plus ions and to remove excess toxic substances. So when there is a fall of the mucosal defenses because of the use of NSAIDs, they are going to be they're going to cause these ulcers. Now, smoking and alcohol can induce and delay healing. Okay, smoking, like alcohol, for example, is uh, a direct toxic substance to the stomach, and male and females roughly have equal incidence. So if you look at the location, 75% of all the ulcers are in duodenum, 25% are in the stomach, and out of all these duodenal ulcers, 90%, at least 75 to 90% are associated with H. pylori. Um, Now, they are located mainly in the anterior wall of the proximal duodenum. Okay, that's important for you to know. You can also see it in the posterior wall, but again, it's in the proximal duodenum. The mechanism is that you're going to have a fall of the mucosal defense mechanisms. There's going to be increased gastric acid secretion, and also there can be an association with Zollinger-Ellison syndrome or gastrinoma, because if you remember correctly, there's usually a increase in the production of gastrin. Okay, when when the parietal cells, for example, are getting damaged, because the gastrin cells, secreting cells are made to secrete more and more gastrin so that they can stimulate the parietal cells more and more, so that they can produce the gastric acid. But essentially, what's happened here is that not only will there be a damage to the parietal cells, okay, should technically decrease the gastric acid production, but also because there's a fall in the mucosal defense mechanisms, there's a sort of a dynamic interaction between the amount of gastric acid that decreases and increases at the same time the mucosal defense mechanisms which are decreasing. So that's but all in all, you have to just know that there's excess gastric acid compared to mucosal defense. Um, right now, these duodenal ulcers are almost never malignant. Another thing is that when with regards to duodenal ulcers, you can also wonder that if H. pylori is infecting mainly the antrum, and if the antrum doesn't have much of parietal cells, right? Why are we talking about parietal cells here? So that's because two things are involved. Number one, the parietal cells getting damaged is mainly associated with peptic ulcers, not duodenal. However, uh, with the progression of chronic gastritis, even the uh, i- with the progression of chronic gastritis, even the ulcers can be formed throughout the stomach. Okay, so there can be a damage to the parietal cells. But in duodenal ulcers and in H. pylori infection, there's a very unique thing that's happening, and that's hyperplasia of gastrin secreting cells, G cells. So normally you would think that, okay, these cells in the antrum should be destroyed. Sure, but for somehow there is a hyperplasia or hyperplasia of G cells. And that means there's again more gastrin. And if there's more gastrin, and if the parietal cells in the stomach are relatively unaffected, the gastrin can act on these unaffected parietal cells in the body and the fundus of the stomach, and they can increase the gastric acid secretion, as shown over here. So it's really a matter of whether the parietal cells are actually damaged or not. So you have different variations. Now, I'll speak more on this in peptic ulcers. And I know it can be confusing, but just remember duodenal ulcers, gastrin secreting cell hyperplasia, as a result, increased gastric acid. At the same time, you could have a decreased gastric acid secretion if the parietal cells in the body and the fundus are getting affected because of chronic gastritis or pangastritis. Uh, Now, there's an increased risk for O blood group. There is, if you look at it histologically, there's hypertrophy of the adrenal glands. Okay, and this is due to increasing demand for mucus secretion. Also, clinically, uh, when you eat, when you eat, basically the so-called concentration of gastric acid is going to decrease because you also have food coming into the solution, right? So in this situation, when you eat, the duodenum prepares itself with defense mechanisms as well. So it's going to secrete, like, stuff from the pancreas and from the liver, etc. They're all going to come in, and they're also more alkalinizing substances. So the fact that you have alkalinizing substances, plus the fact that you have food that's mixing with the gastric acid, and therefore functionally like decreasing the gastric acid concentration, will reduce the harmful stimuli on the ulcers. So this means the pain is actually decreased by eating. Now, gastric ulcers, 75% association with H. pylori. Okay, the location is usually in the lesser curvature of the antrum. Mechanism is again decreased mucosal defenses associated with NSAIDs and bile reflux. Remember, bile reflux was also part of chronic gastritis etiology. Now here you have a risk for sorry. Here you have a risk for malignancies. However, it's still relatively rare, so you still have to take a biopsy though. Now here you have increased risk for blood group A individuals. Here you had a risk for blood group O individuals. Now, epigastric pain increases by eating. Why? Because when you eat, you're going to also increase the gastric acid production, right? But of course, I understand that it's going to get mixed with the gastric acid. But here you have also the alkalinizing substances that are helping. But over here, you only have food and you have more gastric acid production. So as a result, there's going to be increased epigastric pain. So the patient is less likely to eat as much as they would if they didn't have gastric ulcer. And therefore, there can be a weight loss because they're not eating properly. Complications include bleeding. Okay, just mention that there is going to be bleeding. If there is chronic, you can have iron deficiency. If there's acute, it can lead to hematemesis. Okay, hematemesis is like vomiting of blood. And in duodenal ulcer, you can have ulceration of the gastroduodenal artery, and therefore it can cause bleeding. In the gastric ulcer, you can cause ulceration of the left gastric artery. There can be perforation through the wall of the duodenum and the stomach. This can lead to the leakage of gastric acid, which can cause peritonitis. And also, if it touches the pancreas, it can cause acute pancreatitis. Um, Another thing is that the gastric acid can also go retrograde into the pancreas through the ducts, and they can activate the pancreatic enzymes, but I presume that's not very, very common. However, in whatever scenario, the pancreatic enzymes are usually activated by the presence of low pH, right? So if this gastric acid like passes through the perforation and comes either in direct contact with the pancreas or through the ducts, it will basically activate, and yeah, you're going to have acute pancreatitis. And of course, it's a medical emergency. Okay. Penetration. Well, ulcers penetrating the wall into adjacent abdominal organs, like I mentioned again, is pancreas, and the second most would be, for example, the liver. Um, Now, gastric outlet obstruction can also occur. What does it mean? So, when there is edematous swelling and scarring, there can be stenosis of the pyloric part of the stomach or the pylorus. So, in this situation, there's going to be an outlet obstruction. This usually occurs when you have a posterior duodenal ulcer. Now, when there's an obstruction, okay, food can't or even acid can't really flow through the intestine. So, there's going to be regurgitation, and essentially the contraction, the peristalsis, is going to get affected in a way that it's going to actually cause retrograde peristalsis, and it can cause vomiting. Then of course carcinomas, gastric ulcers are more in like gastric ulcers can cause gastric carcinomas. Duodenal ulcers may not really cause much. They're very, very, very rare. If not, they don't cause at all. You have benign ulcers, which are usually small, so it's important for you to know the size. It's small, that's less than 3 centimeters. They are sharply demarcated, okay, the punched out lesions, and they surround by radiating folds of the mucosa. Malignant ulcers are bigger, They're more irregular shaped, and the margin is not flat and sharp, but they're more like heaped up. So it looks like as if you have a mount, like a circumference of mountains. So diagnosis is through endoscopy. Biopsy is only for gastric ulcers, again, because they can cause gastric carcinoma. So you have to be careful about it. Treatment, you remove the stimuli. Okay, so H. pylori eradication to triple therapy of antibiotics and acid suppression using H2 blocker and proton pump inhibitors. So that's about it. It's a pretty small topic, not too big. You can just combine this while studying for acute and chronic gastritis. And yeah, that's about it. Thank you, and I hope you have a wonderful day ahead.